Hello, everybody. My name is Nicholas Swader, and I'm going to be talking about severe combined immunodeficiency, or SCID. So, for over the past 8 weeks, we've learned the importance of the immune system. We've seen the kind of damage that can be wrought with a dysfunctional immune system and how the body was designed to adapt and overcome various pathogens that the world can throw at us. With this PowerPoint, I will be discussing a rare genetic disorder that affects primarily 50 to 100 children in the US born every year. And while this number is pretty low, the children that are affected with the condition have a very hard life. This life is full of obstacles that make it difficult for them to fit in socially, and not to mention the severity of illness that can come from trivial infections of these people. Because of this, SCID earned the nickname the Bubble Boy disease, because in the past, patients were confined to living in sterile bubbles as to not catch infections from the outside world. SCID is a group of rare and genetic disorders that affect the body's immunological ability to fight infections in various ways. And while SCID encompasses more than one area of the immune system, many of the genetic mutations seen in this disease are tied to the T cell and its maturation. As Dr. Cosso puts in his 2010 review article, SCID is a prenatal disorder of T cell development, already present at birth, even if clinically silent. In this PowerPoint, I'll be going through a couple things. I'll be going through a brief overview of the immune system. I'm going to give more information on what SCID is. I'm going to explain how it presents clinically, how it's diagnosed, treatment options, and then prognosis of the disease of the current day. And this will all be in terms of our case study as well. All right, so the immune system can be described as a vast network of cells, cell signals, tissues, and even vessels that facilitate defense from various pathogens. The immune system can be broken up into two major defensive arms: the innate immunity and the adaptive immunity. The innate immune system involves, the body's nonspecific defense mechanisms, such as the skin, and these things last over a brief period of time. And we'll be talking mostly about the adaptive immunity because it is here that the T cells are located. The adaptive immunity is the body's more long-acting, more hyper-specific form of defense. Typically, the adaptive immune system is activated after the innate immunity has been activated and it has not been able to clear a pathogen over a certain amount of time. It's the second arm that's recruited after the first arm has not been able to clear it. The adaptive immune system is broken down into two further subsections: humoral immunity and cell-mediated immunity. Humoral immunity involves the antibodies which are created from B cells, which will travel through the circulatory system and bind and neutralize the specific pathogens. And cell-mediated immunity involves more activation of T cells due to the presence of pathogens, be them foreign or domestic. T cells in the immunity will recognize pathogenic antigens and then kill the cell that's presenting them, usually by inducing apoptosis via the granzyme perforin pathway. All right, so like I mentioned before, SCID constitutes a wide range of genetic disorders that pertain to the development of B and T cells, mostly T cells we'll talk about here. Some of the most common genetic mutations affect the T cell's ability to mature by way of causing a defect in VDJ recombination, for example. This is seen in Artemis, RAG1 and 2, and even some DNA polymerases and DNA ligases. Another way it can cause mutations is by stopping cytokine signaling. So making IL-7R, which is usually secreted for the T cells in lieu of c-Kit. Also with the JAK-STAT pathway, that's another large way that the T cell can be mutated. Defects in the heavy and light chains of TCRs. So VDJ recombination kind of is very closely tied to this, but errors affecting the integrity of the alpha beta or gamma delta chains of these TCRs. Also, there can be issues with thymus development. You can have issues with increased thymocyte apoptosis, right? So thymocyte apoptosis is a very important process of T cell development. However, if you have too much of it, obviously you're not going to be making enough T cells. And there are many more things like ADA or even X-links. While most of these gene mutations are autosomal, there are some gene mutations that are X-linked. So that's very interesting. And actually, a lot of those X-linked genes have different treatment plans for those. Okay. So SCID is a difficult disease to diagnose just by a visual exam, right? The disease is something that emerges in early infancy, but sometimes isn't detected until the body starts to actually encounter a lot of these pathogens that are in the outside world, right? And that can take months, it can take weeks. As we'll see in this case study, the patient presents at a pretty advanced age to start developing SCID or starting to produce the symptoms of SCID. So since the child rarely has to overcome infections and disease in the womb, most SCID babies are born looking pretty healthy. It isn't until later that the signs of SCID start to rear their head. Symptoms such as recurrent and severe infections, failure to thrive, and diarrhea. We'll talk about some other ones, like pneumonia is another one. Since these conditions can overlap a whole lot of other ones like HIV, recurrent pneumonia, cystic fibrosis, early screening and genetic testing is the surefire way to catch it. But without testing, a lot of these SCID patients typically present with severe symptoms, within 3 months. Without treatment, most of these affected children will actually not live to see their first birthday. So it's a very sad disease, but it's one that we are able to treat, as we'll learn a little later. Some other exam findings, such as sparse hair, abnormal dentition, oral thrush, even herpetic dermatitis can be seen and can lead us down the road of SCID. All right, so onto the case study. This particular case was found from and I hope I don't botch this name, but Nkosi Albert Lithuli Hospital in South Africa. Really cool name. So this child is a severely malnourished 4-year-old female that presented to the office or the hospital here for reoccurring anemia and reoccurring rash. The patient was extremely malnourished to the point where they were in the 5th percentile for weight. And the patient was known to have an erythematous rash on her face along with hepatosplenomegaly upon exam. Next, the child was found to be afebrile with mild lymphadenopathy, hepatosplenomegaly, and a rash on the face with a slight systolic murmur. Prior to the patient's visit to the office, this patient was a normal birth, full term. The child was noted to have slight dysmorphic features such as hypertelorism. The mother had a GPA score of 110, and for those who do not know what a GPA score, GPA stands for grava, para, and abort, or abortum, I think. And this is a metric that's used to gauge the mother's success for birth. So grava is the amount of time she's been pregnant, para is the amount of successful births, and abortions are the amount of spontaneous abortions or miscarriage that the mother had. So 110, mother was pregnant once, bore a healthy child, and no abortion. So the child was breastfed for 4 months after that and then was placed on formula. The child had then been admitted to the hospital before, interestingly enough, at the age of 2.5 for a lower respiratory infection that was suspected to be lung tuberculosis. The child was also diagnosed with failure to thrive, which is going to be talked about a little later. And by her current presentation, she was investigated for TB, Epstein-Barr virus, rubella, toxoplasmosis, herpes, hepatitis B, and HIV. She was found to be negative for pretty much all of this except EBV. The patient had, no past surgical history, no past familial history, no travel history, no meds or allergies. At this time, the differential diagnosis was HIV, tuberculosis, recurrent pneumonia, which I would think would be at the top of mind if I were seeing something like this, cystic fibrosis, A-gamma globulinemia, that's a mouthful, and SCID. Okay, so after the patient presentation and history, now we're going to get into investigation and images. So for this patient, a CBC was drawn along with a more exhaustive immunological panel. The patient had labs drawn and was found to be CD4 and CD8 count low. So the CD8-4 count was about 35 cells per microliter. CD8 count was about 65 cells per microliter. The natural killer cell count was about 138 cells per microliter. That's about normal. And she had a gamma GT level of 77, which was found to be severely decreased from a prior visit where her last value for this was 213. A patient had a bone marrow papavirus test, which was completed and positive. While this didn't necessarily point to SCID being our main culprit here, low CD4 and low CD8 levels coupled with this may lead us to think there's an immune deficit process going on here. The patient also had a liver and skin biopsy performed, which showed us mild portal tract infection and deep-seated histiocytic infiltrate within the subcutaneous tissue, respectively. So, mild infection in the hepatic portal tract and infiltrate. So skin infections are pretty common with SCID patients, as their immune system is not rigorous enough to be able to deal with these infections well. So the patient also had a chest X-ray completed during her stay. You can see minor pneumonitis in both fields, right near the mediastinum. So yeah. All this kind of pointed to SCID or another immunological process pointing on. All right, so what does this all mean? For right now, I mean, it means we're looking at some sort of immunodeficiency. The blood cell count got us on the right track. And as we talked about earlier, SCID is a life-threatening syndrome that results from numerous molecular defects leading to severe T and B cell dysfunction. So diagnostic criteria for SCID is less than 0.3 times 10 to the 9 liters for CD3 T cells, or less than 20% CD3 and CD4 cells with naive cell markers. So this child was a candidate at this point, right? We talked about abnormally low CD3 and CD4 levels there. I believe it was a leukocytopenia that the patient was diagnosed with our last metabolic panel. And then with this, the patient also has to present with one or more of the following. So the first thing it could present with is abnormal TRECs. Either upon a birth screening or another screening, family history of SCID, or reoccurrent opportunistic infections, and that is the one that our patient passed with flying colors. Also, features of Omen syndrome can also be a pretty early indicator the patient here did not have that. Most patients with SCID will present within the first few months of life, as we talked about. But for our patient who presented at the age of 4, this isn't the case. However, I mean, we can see that she appeared to the hospital at 2.5, but even then, that's pretty old. So why is SCID so deadly? The answer comes when we look at the specific parts of T and B cell development. And in order for T and B cells to be able to recognize virtually any antigen and bind to them, I guess I should say the ability for the T cells and B cells to recognize antigens, each one is specific to only one type of antigen, but the possibilities are endless for the possible combinations of TCR binding sites. But in order for them to recognize these antigens, they need a way to generate unique receptors that have the potential to find antigens with structures that they haven't encountered yet. So in comes VDJ recombination. Now, I'm not going to get into the exact process of VDJ recombination because we've gone through this at exhaustive lengths in class. But it is a process that these T and B cells are able to bind to a limitless number of antigens. A majority of cases of SCID have genetic mutations that affect protein mediators of VDJ recombination, like RAG, Artemis, Q70, and even DNA polymerases and ligases. So from that past PowerPoint slide, we can see that issues in the development of T and B cell receptors inhibit the body's adequate response to an infection because, well, we can't bind to it. How do we know it's bad, or how do we kind of sight in towards this particular pathogen if we don't have a target? So initial treatment for our patient would be the infusion. First of all, we got to deal with the anemia. So the infusion of packed red blood cells to curb, again, this anemia. This is a short-term solution, right, to a long-term problem. While this could maybe have the patient feel a whole lot better, it will not solve our problem. The patient also received immunoglobulin infusions. This is, again, prophylactic. While the patients wait for a bone marrow transplant, we can try to give them a little bit more passive immunity while they wait. Again, this is not going to solve their problem. And if we were to continue to do this for SCID patients, they would, again, not last very long. So the main treatment for SCID is bone marrow transplantation. So it's important to find the optimal donor. This is across a lot of the research that I've done. Finding an optimal donor, usually a living relative, increases the positive outcome to up to 85 to 90% survival. So again, the main issue is finding a compatible donor, usually being a family member. The patient is usually given targeted chemotherapy to eliminate any remaining T cells and further immunosuppression to prepare the donor bone marrow sites. Another promising treatment is genetic therapy. This therapy involves inducing a virus containing the corrected gene sequence of which was mutated. While recent trials have been effective in treating ADA SCID or X-linked SCID, there are other possible unintended outcomes, like for the failure of the fixed gene to meet its target, or sometimes resulting in off-target mutations causing something like leukemia. Another really good therapy choice is enzyme replacement therapy that's available for those specific types of SCID like ADA or adenosine deaminase SCID. So in this type of SCID, you have a lot of cellular debris and junk that accumulates because ADA has not been able to do its job because it has been mutated, and this will build up in T cells, causing them to die. So enzyme replacement therapy, really great for ADA SCID. So the outcome for SCID patients in the present day is pretty hopeful. What once was a lethal condition is now one that can be treated. We can give the patient a normally functioning immune system after we're done with this treatment, which is really awesome. These patients will thankfully, go on to live a long life, possibly even having a family down the line. And with having a family, it's important to realize that these patients, for these patients, that there is a hereditary factor, right? So that must be kept in mind when we're helping them, create a family, that the patient, needs early screening treatment for this baby that's about to come would, be the utmost importance, because that would give us the best chance of saving their life. It's also really important to know that while the patient was given immunoglobulin therapy, as I talked about earlier, this therapy isn't sufficient for treatment. Patient must receive hematopoietic stem cell / bone marrow transplants, and since this treatment has not since the treatment in our case study here, the patient has not returned back to the hospital. So I'm assuming this would imply a successful transplant and the recession back to a normal life for the patient. Anyway, thank you guys so much for listening to my PowerPoint, my little talk of SCID, and in the next slide my references. So thank you and have a great day.